Good evening. Thank you for that alert. Good evening, everyone. My name is Melissa Spiel. I'm one of the maternal-fetal medicine physicians at Beth Israel, and I'm joined here by my colleague, Dr. Katharine Germansky, who's one of our gastroenterology colleagues at Beth Israel as well. And we're here to talk with you a little bit about inflammatory bowel disease in pregnancy, and specifically how we can use a multidisciplinary team approach to care of these patients. So just to remind everyone, IBD is increasing in the US, and it's often diagnosed in younger patients, usually those who are contemplating pregnancy or conception soon. And in some patients, these pregnancies can be at higher risk and require additional management, but it's not necessarily contraindicated. And generally speaking, co-management of pregnancy with multidisciplinary care can really optimize IBD outcomes and also pregnancy outcomes. So what are we going to talk through today? We're going to use an ideal or non-ideal patient. Her name is Megan, and talk through some of the issues that she encountered during her pregnancy and review some preconception discussions, pregnancy management strategies, and delivery considerations, as well as postpartum care for this patient and in IBD patients in general.
Great. So thanks, Melissa, for starting us off. This is Megan. She will lead us through our talk today. So she's a 34-year-old who had a history of ulcerative colitis diagnosed at age 14. And she failed available medical therapy at the time and required an open total colectomy and ileopouch anal anastomosis shortly thereafter, age 16. And since that time, she had had a couple admissions for small bowel obstructions, 2 required lysis of adhesions, but otherwise had done pretty well in between those episodes. She then developed diarrhea many years later, 2019, and was found to have pouchitis on a pouchoscopy. She was treated with metronidazole, and this was followed by a short course of VSL number 3, a probiotic. And since that time, she really didn't have any follow-up, but was overall doing okay. She presented to establish IBD care after moving to Boston and, really was all over the place, had lots of new symptoms, including nocturnal diarrhea, abdominal pain, weight loss, really was not feeling well in the middle of a move. It was not an ideal situation. And then, of course, to make things even more difficult, she was grieving a recent miscarriage and really desired pregnancy. She had never been pregnant before and was having a really hard time just kind of managing this entire situation. So, as you can imagine, lots of questions in our initial visit, mostly surrounding preconception, which was great, but really just so concerned about her symptoms. Would she really be able to conceive with all of these symptoms? Would she need medications? Are the medications safe? Did she have to change her diet? If she was able to conceive, would she pass on IBD? And it was just, all of the questions she should have been thinking about, which was great, but you could see how this was a really tough time for her.
That brings up a little bit about how we would start our preconception counseling and considerations. And, Katie, for these patients, when they come to you, how do you counsel them about risks to their offspring of passing on IBD?
Yeah, I think this is like a very hot topic on their minds, when they're thinking about, often other people around them are having children and they're thinking about if they want to conceive. And this is a big question for them. Are they going to pass down this disease, especially if they're having symptoms of their own? But we counsel that the absolute risk is overall pretty low. So if mom has Crohn's, the reported risk is only 2.7%. And for ulcerative colitis, that risk is only 1.6%. And I think this is comforting to patients who are concerned. If both parents have IBD, there is a small study that suggests the risk exceeds 30%, which is not as reassuring, but helpful for them to know while planning. There is also a phenomenon called genetic anticipation, and typically seen in cases of familial Crohn's, where patients could present in future generations at younger ages and typically with increasing disease severity. So, once a patient decides this is the right thing for them and they want to get pregnant, we often send them to you for this initial conversation. What next, right? Like, how does this actually happen? What do they need to do?
Absolutely. And our conversation with patients with IBD is probably similar to other patients at first, which depends a little bit on age, but ideally spontaneous conception should be tried first. And, the part of the problem with individuals with IBD is that there may be some difficulties or obstacles to them achieving a spontaneous conception, which may be around reduced sexual function, body image concerns, and then just fear of infertility. These women and patients have had this disease for quite a long time and may have been counseled that they could never achieve a pregnancy. And then you also have a population who just are what we call voluntarily childless. And these individuals may be avoiding pregnancy just partly for reasons of fear of inheritance. You spoke a little bit about dual family members, maybe poor counseling on risk of inheritance previously. There are concerns around caretaker ability. These individuals unfortunately may have a lot of care on their own to take care of their own well-being, and then thinking about bringing a baby into the mix can be challenging. Then there's also the concerns around medication exposures and congenital anomaly risks. So it's really challenging, but our preferred first-line strategy is to try and conceive on one's own. When we're thinking about fertility risks for individuals, regardless of, a mode of conception, individuals who have quiescent IBD seem to have similar rates of fertility as those who are not suffering from IBD. However, there is some suggestion that active Crohn's disease may reduce fertility. And this is one of the many reasons why we really strive to have disease in remission prior to conception. There may also be an increased risk of infertility related to surgery or adhesive disease. If someone has surgery for Crohn's or ulcerative colitis, there may be scar tissue in the pelvic organs, which can be hindering one's ability to get pregnant.
So at what point would you consider referring patients to reproductive endocrinology?
Yeah, absolutely. And so this is also a conversation or a decision point depending on one's age. So if someone's relatively young and has some time to attempt a spontaneous conception, the referral can be postponed for 6 to 12 months. If someone is on the older side, that you may not want to wait that long due to concerns around ovarian reserve. And specifically in some patients with colonic Crohn's disease over the age of 30, they may have even reduced ovarian reserve. And then getting back to the point on surgery in the past, is there a concern for tubal adhesive disease? And these patients should get a referral probably sooner rather than later. And importantly, if one does have assisted reproductive technology to assist in pregnancy, they seem to have equal chances of achieving a live birth. Well, Katie, when someone comes to your office like Megan and is contemplating pregnancy, how do you go about discussing this with them?
So it's definitely a loaded visit. And there's lots of things to kind of touch on and make sure we've established really for the best outcome of, I think satisfaction during pregnancy. So of course we're talking about fertility and seeing what expectations are. I like to insert myself into a couple very quickly as the third wheel and find out really, what are they thinking about in the next couple of years? Are they considering family planning? Where are they at in that process, and what potential misconceptions or information that's been incorrect has been given to them before. So it's really a little bit of a data gathering moment. Also, of course, talking to them about their disease control. So, what medications are they on? Are they working? How are they feeling? Just getting that initial assessment done is really important to help figure out, is this going to fit with their timeline? And then, of course, involving any consults that are necessary, including nutrition. MFM is my favorite one to consult nice and early. And then thinking about a colorectal surgeon, have they had a prior surgery? Do they need a surgery? Should we get them involved now? Sooner is always better in my mind from that perspective. And then, of course, just routine healthcare maintenance. So making sure they're up to date with all of the little nitty gritty details of taking care of an IBD patient so that we don't have to do that while they're pregnant. So, the first thing I do is send somebody who I think is at elevated risk for complications to MFM. And so I'm curious, what's your conversation like with them at that initial visit? What are you counseling about in regards to obstetric risks?
Yeah, that's a great question. I think it depends a little bit on the individual's disease severity at that moment in time, whether or not the patient's in remission, and sort of what are their other comorbidities that may be complicating their pregnancy moving forward. On this table here are some of the obstetric risks that have been quoted in the literature. Some of them have been disproven in follow-up studies. And part of what we really try and stress is that a pregnancy in disease remission is likely to have better outcomes. And similarly, risk of miscarriage is probably on par with the general population. Risk of fetal growth restrictions probably on par with the general population, and preterm delivery has been suggested less than 37 weeks, but it's unclear, again, is this related to severity of disease or flares during the pregnancy or other comorbidities. And stillbirth risk is a scary one, but really hasn't been substantiated in the general population of individuals with IBD disease. So maybe this risk is increased of, certainly if there's surgery or other concerns that are occurring during the pregnancy. But then it's also important to discuss with IBD patients that there could be delivery complications. Some of those that have been quoted are bleeding risks and clotting risks, as well as risks to complicated perianal repairs and disease. And there seems to be an increased risk of cesarean birth, whether that's because individuals are afraid to attempt a vaginal delivery or because they're being counseled to have a cesarean delivery to ensure that they don't have adverse IBD outcomes later on. And then, of course, this is the optimal time to ensure that patients are on the appropriate medications that are safe for pregnancy and certainly avoiding teratogenic risks. But, when we talk through some of these obstetric conversations, we're also thinking, what's the risk of flares during pregnancy? And so, Katie, what are some things that you would tell your patients about pregnancy in the setting of IBD disease?
Yeah, so this is definitely like a really important conversation because I think everything, like you said, alluded to, really surrounds disease activity. And so that's the main conversation is, if we can ensure that your disease is inactive, it's going to help reduce all of these GI risks. So of course, the risk of flare, and then subsequent, risk of incontinence or anal sphincter issues, risk of pouch dysfunction, of course, need for surgery during pregnancy. And then, of course, additional vitamin and nutrient deficiencies, in addition to those that are common to pregnancy already. But, if we look at the data for a patient with Crohn's and a patient with ulcerative colitis, this is, tried and true 1986 data that really is so crucial to review with patients. So this is patients who have Crohn's disease looking at if they go into pregnancy with inactive disease or with active disease. And on the left, we see that those who enter into pregnancy with inactive disease do much better. So 2/3 of people will not have any relapse and will not have a flare versus 1/3 will. Of course, you can't, predict everything and you can't, completely eliminate risk, but this really reduces risk compared to those on the right side who have active disease, the risk here is that 2/3 will have continued activity or worsened activity. And the same is true for ulcerative colitis. These charts look almost identical. We call this the rule of threes. And if you can go into a pregnancy with control disease, that's really going to set you up for the best success moving forward. And of course, that's really our goal to drive home.
Well, that looks pretty impressive to me, Katie. Disease remission seems like the way to go, but how do you define disease remission, and what are you really hoping for?
Yeah, so remission is a loaded word and defined differently, in different papers and by different people. But the key to remission, of course, is to have the patient feel well. So a clinical remission, of course, something patients can definitely get behind when they're not feeling well, especially when they're thinking about adding another human to their world. But it really also involves healing. And so a true remission that we're looking for is both clinical remission of symptoms and healing seen on both endoscopy and imaging. And ideally, we would see that for 3 to 6 months, including 3 months stability on their current regimen to know that it's going to last and not be this transient idea. Of course, we want medications to be continued and really to avoid non-adherence in these patients. We also have a goal of adequate drug levels, especially preconception. We do know that drug levels can change a bit, especially in patients on infliximab, but really the goal is for an adequate drug level in the preconception period, showing that patients have, again, clinical response in addition to confirmation of remission and healing on imaging, such as an MRI or colonoscopy or other sorts of endoscopy. We can also use something called a baseline fecal calprotectin, and then use this to trend it during pregnancy as well to see that we've achieved response and ideally remission.
That's an interesting test. Fetal calprotectin, is that something that we should be ordering in the OB office when you have prenatal care?
I order enough of these probably for everybody, so you don't have to, but it really is a great non-invasive marker. It's actually a neutrophil specific calcium and zinc binding protein. And the amount of calprotectin that returns on the test reflects the number of recruited neutrophils and therefore the amount of inflammation that's gut specific. So it's even better than thinking about like a CRP or ESR, which we know can change in pregnancy as well. So it's actually indicated for many things. So again, non-invasive assessment of GI inflammation. We can use it to monitor response to therapy or to surgery, or even to predict relapse in IBD. We also use it to distinguish between IBS and IBD. It's really a great marker, but really the key piece here is that it is stable in pregnancy, so it can be used, throughout the 3 trimesters and the postpartum period. And again, a great non-invasive way to evaluate for disease activity.
That's great. And then, patients often come to us in the preconception period, either on medicine or wondering about whether or not they can use certain medications. I'd say the most common agent I've seen prescribed is mesalamine. And we should be pretty reassuring about this medication during pregnancy. The newer formulations are phthalate free, so really very low risk to pregnancy. And then sulfasalazine is probably another common agent that is used and can be used. We just need to make sure that we're recommending supplemental folic acid and to reduce the neural tube defect risk. With regard to steroids and antibiotics, which are commonly used for flares, of course, you're trying to avoid a preconception flare, but if those are needed or indicated, then they can be used. We just want to try and avoid steroid use in the first trimester if possible, due to concerns for cleft lip and palate. With regard to those common antibiotics, amoxicillin and metronidazole are more commonly used due to concerns around ciprofloxacin's association with cartilage disorders, but certainly can be used in certain circumstances. And then you have a group of agents called the thiopurines. Most of us are familiar with methotrexate as we use this for other indications, but really this is the big one that you want to try and get your patients off of at least 3 months prior to pregnancy. And I've not really commonly seen these other agents used, Katie. You want to comment on whether or not you use these and whether, we really should be worried about patients when they come in on them.
Yeah, I mean, I think the thiopurines, if somebody's been stable on it for a long time, that's not as big of an issue. But of course, new starts bring potential, new risks. And then, thinking about cyclosporin is, you're in a whole different ballpark there if you're thinking about initiation of cyclosporin, and that's just a complicated decision based on benefits and risks and other options available, including surgery. So that's a tough one. Hopefully, we don't have to do that anytime soon. And I think that's all really thanks to this, next group of medications really being the biologics, which hopefully will make all of our jobs easier long term, given their safety profile. I mean, this is, all compatible with pregnancy, really disease modifying agents to try to prevent these, these risks we're talking about associated with IBD, and then of course the associated obstetric complications. All compatible in pregnancy. We do kind of tinker with the dose a little bit and the timing of the last dose around delivery if possible. And this is really just to minimize exposure to the baby based on half-life. But it's not a huge issue if it's not perfect. So these are really safe drugs to use in these first three categories: anti-TNF, anti-integrins, and of course IL-12/23 blockade or Stelara. Of course, there are new drugs on the market all the time, including the JAK2 inhibitors, including S1Ps. And this is still new to all of us. We are seeing, of course, risk of malformation in Xeljanz patients and fetal blood vessel malformations in ozanimod, all in animal studies, of course, limited human exposure and human data. And so washouts are recommended for these. But I think at this point, it just brings up a great, opportunity to talk like, what's the game plan here, right? What's the long-term plan for both your IBD and, your family planning? And so it really, hopefully prompts the gastroenterologist to bring this up and to talk about it with a patient, because of course, by the time they see the OB or by the time they see the MFM, they might not have had that same opportunity. So.
And then there's, considerations besides medical therapy around surgery. And I guess, part of our counseling, if someone's contemplating surgery, is, what is the current disease status? What is the patient's quality of life? Are you recommending surgery for a patient? And what is their long-term plan for pregnancy? Is it better to have the surgery prior to conception? And how will it affect a patient's ability to get pregnant? We're going to talk a little bit more about that moving forward. But also, if one has entered into your office with surgical background, what are the risks to pregnancy? Should they go and seek out their colorectal surgeon in decisions around delivery planning? And what are the common surgeries that you might see individuals come in with? There's something called an ileopouch anal anastomosis, which has kind of two main strategies that individuals might have. One is an open approach, and one is a laparoscopic approach. And patients certainly don't have a choice as to which mode their surgeon's going to attempt per se, but if they did have an open approach, or if they're contemplating an open approach, this seems to have higher infertility rates, likely due to some of the adhesive disease in the pelvic organs, hydrosalpinx, destruction of the fimbria, tubal destruction, whereas interestingly, laparoscopic approach seems to have much less risk of infertility. In this study, listed here, there was a median pregnancy interval of about 3.5 months with a laparoscopic approach, as compared to an open approach where 9 months were needed to achieve pregnancy after an open procedure. And down here, I just wanted to show you a quick picture of what these type of anastomosis will look like, and how this helps to achieve continuity for your patients.
Yeah, it's so interesting because this discussion around surgery and timing is just so, woven into the discussion around family planning. We have some patients who decide to, have part of the surgery with either, ileal resection or a colonic resection and a temporary ileostomy. But not having the reconnection until after they've completed family planning to try to mitigate some of the, hands in the pelvis, like risk of infertility from that perspective. So it's just all comes back to that individualized, care conversations for each patient. I think, as we're also trying to kind of put together this, kind of full body approach, we're really also thinking about what kind of health maintenance do they need to have preconception, just to kind of streamline things while they're pregnant, make sure their cancer screening is up to date with pap smears and colonoscopy, of course, make sure they're vaccinated, thinking about substance cessation and nutrition ahead of time, of course, vitamins and potentially folic acid. And then thinking about contraception if they're not just quite ready yet, because sometimes there are surprises, and this is one way to mitigate that. Great. So, Megan is, comes to us really kind of not feeling well, concerned, uncertain about her future. And we decided to start with a restaging. So, what is the status of her disease and how can we optimize this to really optimize her care and achieve that remission? So she has a restaging evaluation and she is starts off with labs. We find that she is iron deficient, anemic, B12 deficient. We see that she has an elevated CRP and that elevated stool inflammatory marker, the fecal calprotectin. She has a pouchoscopy, which shows ulceration in the small intestine and the pouch, and biopsies that confirm both chronic and active inflammation. And her MRI to evaluate the more proximal small intestine shows the same thing. So 20 centimeters of acute on chronic ulceration and inflammation. And really all of this is suggestive of Crohn's disease after having ulcerative colitis and having her colon removed, which is, clearly unfortunate and a tough diagnosis to kind of swallow. So she comes to see me in follow-up and to put a treatment plan together. And guess what? We're pregnant. It just happened. I don't know how, right? The whole conversation, but obviously very exciting. She was thrilled. Didn't think she could really conceive with all of her symptoms, but did. And we decided to start her on Humira, so first-line therapy for Crohn's disease, put a prior auth in place, referred her to nutrition. She was, again, having some weight loss. Even at that point in time, we referred her to see colorectal surgery, again, have the conversations about what's going to happen, what could happen around delivery. She did already have a mental health care provider, which was great. So she continued to follow with them. And she was on a prenatal vitamin, and we just optimized her folic acid in the setting of, having lots of active inflammation. So off to the races with pregnancy. Here we go. Melissa, what do we do now?
I know, this is so great. This is classic situation where you have a patient who you're trying to optimize beforehand, but, we don't always have the full opportunity to talk through pregnancy. But, there are some individuals who do magically come into pregnancy in remission. Magically, I'm saying jokingly, of course, it's due to your great care, Katie. But if someone comes into pregnancy without active disease or isn't flares within the most recent months, you can probably reassure your patient that their disease outcome is likely not to impact their pregnancy. You can follow them routinely. You could argue for a third trimester growth ultrasound as a screen for fetal growth restriction, although as we discussed before, the data is quite limited on and controversial in that area. And you want to be aware of some of the discussions that your patient may be hearing from other providers. And also you want to talk through some of the conversations about mode of delivery. And part of that conversation is looking at the perineum and looking for active disease. And you may or may not feel comfortable doing that as an obstetrician. And in that case, you would have your gastroenterology colleague help you with that decision process, and ask that your gastroenterology friend, phone a friend, see your patient at least once during the first and second trimester, and then as needed. On the slide here are some of the common labs that do get checked in pregnancy, but probably if they're going to follow with Katie or one of her partners, they're going to be checking these as well anyways.
Yeah. But I agree with you, like someone coming into pregnancy and remission, they look like a non-IBD patient, right? They all get constipation, they get some GERD. I feel like I'm not an IBD provider during these times because it typically tends to go really well. We of course are thoughtful about, their iron and their B12 levels and thinking about, iron and constipation. But besides that, it's really all about, are they gaining weight? Do they need an early nutritional consult if they've had prior surgery? And then of course, monitoring for active disease. So it is pretty straightforward when they're in remission, which is great.
But then, coming back to the medications, this is really your opportunity to ensure that your patients feel comfortable staying on the medications that they entered pregnancy on, that this will help them stay in remission and probably reduce the risk of flares during the pregnancy. Just to remind, green is good. So we'll be continuing those during the pregnancy.
I think it's so helpful for a patient to hear that from both their OB or from MFM and from GI, because a lot of the misconception happens outside of our office or online, and just being able to reinforce that these are safe is extremely helpful, because I think the adherence rates start to go up. But in regards to our patient, so she did start on Humira, again, one of those green is good medications. And our plan was to have her Humira level checked. She did have some ongoing symptoms in her second trimester, so we added on some budesonide to help, initiate symptomatic improvement. She also saw nutrition actually pretty closely. She really struggled with weight gain and a little bit of hydration given the amount of diarrhea she was having. And we, of course, supplemented her. She needed some iron, she needed some choline, a little bit of vitamin D. Of course, continuing on her prenatal and folic acid was really important.
So this brings up a good point, Katie, is, how do you manage, or what do you think through in a patient with a flare? So from an OB perspective, I know we're worried, how's the baby going to tolerate the flare in pregnancy? And there's very little data to guide surveillance, but it might be reasonable to consider growth ultrasounds to ensure there's no risk of fetal growth restriction. With regard to fetal testing, as we spoke about before, there's probably not a lot of data around usefulness of biophysical profiles or non-stress tests, but it may depend on the clinical circumstance and how severe is the flare? Is the patient in the hospital with really bad bleeding, and what else is going on? This slide comes from an expert opinion who was suggesting that there's cervical length surveillance, probably because of the risk of preterm birth less than 37 weeks. From an OB perspective, we don't usually treat this patient population any different than our others, individuals who come in for a scan. We do routinely do at least an abdominal cervical length in this time frame to make sure that there isn't a risk of a short cervix. So for the most part, our screening, our surveillance strategies have limited data to support, but we would certainly try and follow along to optimize and ensure that there's a good outcome for baby in conjunction with the IBD disease. One thing just to consider when you have patients who have an active flare is if they are on steroids, that this will increase their risk of gestational diabetes. So it may be reasonable to either screen early for diabetes of pregnancy, and then again, later on in the pregnancy, depending on how long they've been on that therapy. And then, of course, counseling around mode of delivery. If the active flare is in the perineum, this may impact your mode of delivery.
Yeah, so, I think the kind of rule of thumb is to think about your patients when they're pregnant similarly to when they're not pregnant. You don't want to really withhold something from them just because they're pregnant. I think that's a hard thing to kind of do sometimes, but there are options, and those restaging options beyond the labs, beyond the stool testing we talked about already, are, of course, an endoscopic approach. So thinking about a flexig or a pouchoscopy, you're going to get a lot of information just from that. And hopefully you don't need to do a colonoscopy or, God forbid, an endoscopy. We try to stay away from those unless the outcome is really, really going to change the medical management. We really don't need these in the vast majority of patients. Now, a flexig or a pouchoscopy can be done, unsedated. It really takes 5 minutes. Some people are not okay with that and they still would like some propofol, and, that's okay. We try to, again, time this in the second trimester. If you really need something in the third trimester, I call my friendly MFM and say, like, do we want to do some fetal monitoring? Do you want to do mom's monitoring? How much extra care do we need to really optimize the outcome? But again, really a 5-minute test should give you a ton of information just from that. And that shouldn't be withheld. And then thinking about, an MRI, of course, we try to avoid gadolinium use, and we really don't need it, again, in the vast majority of patients. And this has really become standard of care. There is some research looking into ultrasound for TI evaluation, but not something that we are clinically using right now. And then, of course, CAT scans and x-rays, again, trying to limit based on radiation. So, flexig, MRI, labs, fecal calpro, gives us the, tons of information. So if we need to do it during pregnancy, we can.
Yeah, that's a great point. And we would support that too. We're really trying to ensure that we get the best outcome for the patient. And we don't want to withhold strategies for investigation and or withhold strategies for surgery if indicated. Now, this is an important point, though. We really try and avoid surgery because of fetal mortality risks. However, if a patient truly needs surgery, you're thinking about the risk to mom and baby in the absence of surgery, and certainly in the setting of perforation or a complicated obstruction or abscess, surgery may be the right course of action. And we would rely on gastroenterology and colorectal surgery to guide us in figuring out if that is really what's the best course of action for your patient. If we could pick which trimester to do a surgery in, of course, we would pick the second trimester prior to viability. But unfortunately, most of the time, surgery comes up in an urgent setting and it's unpredictable. It's not really a circumstance where you can say, I'm going to just wait till next month to do this. But it's an important conversation. And in this setting, especially multidisciplinary care is really important.
And this is definitely like one of those instances where I think having that early multidisciplinary care is just so helpful. If they've already met the surgeon and MFM, as best you can, I think it makes these conversations easier. But, sometimes they're not easy and sometimes you need to have surgery. And if we do, there's one thing that we often will try to counsel on is a temporary ileostomy to try to reduce the risk of leak, of course, and intra-abdominal infection if possible. So tough conversations, hopefully one to avoid, again, with kind of disease modifying biologics used early.
Mm-hmm. Now, if you get through a pregnancy without having surgery, it's a win, I think, at least.
For sure.
And then you get to talk about delivery considerations. So, mode of delivery is a tough conversation for IBD patients. A lot of times they come into our office with some guidance from a provider, 10, 15 years ago, or they have some real concerns. But this is really the point where we can start to talk about talk about the goals of care, talk about what they're really hoping to get out of their delivery experience. And for the most part, pretty much anyone with IBD can have a vaginal delivery. That's even in the setting of surgical history, ostomies, IPAA is still achievable. And really sometimes they desire vaginal delivery because they're hoping to avoid some of the risks of adhesive disease or a difficult cesarean birth. But importantly, we need to talk about the possibility of complicated lacerations that can occur. We certainly would favor a laceration over an episiotomy. Episiotomies seem to predispose to perianal disease, even in individuals that haven't had it before. So this should be part of our conversation. The other big way to deliver babies is by cesarean delivery, and we do it for many obstetric indications. There are some circumstances with active perianal disease or rectovaginal fistulas where patients may really want to avoid vaginal delivery due to concerns around complicated repairs or issues around sphincter function. And this comes up not infrequently with women who've had surgery and an IPA because they're trying to avoid that irrevocable or irreparable fecal incontinence.
Yeah, this was actually an important conversation to our patient, Megan. She had, of course, the IPAA. She'd also had small bowel obstruction. She had lysis of adhesions in the past. So, she was really seeing the pros and cons of both sides. However, fecal incontinence was a key word for her. And she just could not, that was an unacceptable risk. And so for her, she really wanted a cesarean section. And, felt very strongly about that from the first conversation. So it is interesting how, again, that kind of, individualized conversation can push people in different directions. Mm-hmm. So she had a pretty interesting third trimester. She was able to come off of the budesonide. She did have return of symptoms thereafter. We did have to push up her Humira to weekly, and she didn't actually get a Humira level checked until a little bit later for some reason. But she was seen by all of her consultants. Of course, she saw myself, and she saw MFM. She did see colorectal surgery again to kind of think about them being present for the C-section, given her prior adhesive disease. She followed closely with nutrition, really struggling with weight. She developed new pruritus and actually was found to have cholestasis of pregnancy. So this really led to a scheduled C-section at 37 weeks, but fortunately had a very healthy baby boy. A little small, so 8th percentile overall. And actually Melissa was able to deliver her. So it was really exciting.
Yeah, in this case, also brings up a point around having a surgical backup in case you're worried about adhesive disease. Fortunately, her case was pretty uncomplicated. The uterus pushed most of the bowel out of the way, and there was only some adhesions of the omentum to the lower uterine segment. So we really lucked out in this case, but if there were more adhesive disease or concerns around risk of enterotomy or entry into the belly, it's important to be able to feel comfortable that you have a surgeon who can back you up and help you repair those issues.
Yeah.
Well, and then she was delivered, right? So then we have to think through postpartum, and probably the most common concerns for women are around lactation and breastfeeding. So Katie, what are some of your guidance around lactation?
Yeah, so Megan actually was really interested in breastfeeding, and things seemed to go off without a hitch. And one of the conversations we had, before she delivered was actually there's some data in non-IBD moms that there's a protective effect in the development of early onset IBD. And so moms love this, and they're really looking to see if there's any data that can kind of push them one way or another. And I would say most of the moms that I see, will try to breastfeed with this info. She actually did pretty well in terms of thinking about nutrition and hydration, but something, of course, to kind of factor into patients who may have active disease while they're breastfeeding. And there's often questions about fenugreek for patients who have difficulty with milk supply, but this is one thing we would avoid given reports of diarrhea and bleeding. Not exactly sure the mechanism there. And then, I think we talked about this before, but Melissa, can you just review again, thinking about our IBD meds in the lactation period?
So back to that slide, but not quite the whole slide with the table, there are some considerations around medication use in breastfeeding. Generally, we want women to breastfeed, but if they are on sulfasalazine, maybe they should avoid it if possible. There may be an increased risk of neonatal infections. Again, this is evolving data. Katie may be able to speak a little bit more to this, but if a newborn is, going to get an infection, it's probably not going to be a severe infection. So probably should be pretty reassuring on this front. Of course, we want to avoid methotrexate and some of those other teratogenic agents, not because of teratogenicity, but other concerns with breastfeeding and passing on the drugs to the infant. And
Perfect.
then, yeah, sorry, go ahead, Katie.
Oh, no, I was just going to say that, Megan's postpartum clinical course actually went exceedingly well. So her little boy's now 6 months old and he's done great. He has not had any evidence of infections. He's been meeting his milestones as we would anticipate. He's been gaining weight from that 8th percentile. And the only, kind of slight modification we made with his pediatrician was to avoid the rotavirus vaccine, since he was born to mom who was on Humira and he had exposure both postpartum and both peripartum and in the postpartum period through breast milk. And I really just advise moms to kind of make sure their pediatrician or future pediatrician feels comfortable, given this, really slight increase in risk of infections in that initial first 6 to 12 months. So it's really thinking about kind of the live virus risk for vaccinations, and then of course the slight increased risk in typically non-significant infections. And Megan is really loving motherhood and thriving. It's kind of amazing to see, this progression she's made over the past year and a half, from coming in just, with everything kind of up in the air to now feeling really solidly grounded as a mom. And she's feeling well, which of course helps. She's on weekly Humira, tolerating injections without any issue. And she had a restaging evaluation. This is actually her pouchoscopy pictures on the right, which are, really significantly improved from prior. It's kind of amazing what Humira can do, but she, doesn't have any more ulceration. So we've seen healing, and her MRI also showed improvement as well. I just saw her in follow-up and she told me they're thinking about number 2. So we might need another session to kind of pull things back together after that experience. But I'm hoping that with this remission, a future pregnancy would be much easier. So.
Great. That's wonderful to hear. Well, I hope at least she had a good experience, and even though she was flaring during the pregnancy. So I think this brings up kind of our important take-home points, is that pregnancy in IBD patients, especially if there's active disease, can be complicated, and it's probably best co-managed with gastroenterology and MFM. Albeit said, in more mild cases, you probably don't need as much intervention. And then preconception counseling is really the best time to sort of reflect on what's the disease status, what's the pregnancy risks, is there active disease, and medication titrations, and really trying to optimize prior to conception is the goal, if you have the opportunity to see someone before they conceive. All right, well, thank you. And Katie and I will take any questions if you have any.
I think I see a couple questions here in the question and answer. Thank you so much for the questions. So Melissa, the first one is, can you discuss current understanding around C-section in the absence of current or past rectal or perianal disease is protective against higher order obstetric lacerations or future fistula?
Yeah, I think this data is not clearly known. If you do not have active disease in that area, there is limited information to suggest that you will have future perianal disease, albeit if there is an episiotomy, that seems to be one of the big risk factors. So if we can avoid episiotomy, which we're already trying to do from an obstetric perspective, then we should be able to have a vaginal delivery without a complicated postpartum course or perianal disease. Do you agree, Katie? I mean, you see these patients too.
I do. I think the most important thing is just asking about it. I think a lot of times, if patients, have been seen by somebody else or they come to your care and you don't know them as well, it's, have they had prior perianal disease? Did they ever have an anal fissure or a fistula or anything down there that they needed to take a peek at? And if there's any concern, to get an MRI of the pelvis ahead of time. I'm all about the preconception evaluation, just knowing what we're in for. So I think it's just asking about it. And then, the other things that come up are, of course, pelvic floor dysfunction after healed inflammatory bowel disease. And, are they able to empty out completely from their bowels, even if things are healed? So trying to assess motility as well, preconception, knowing that everything will change after pregnancy again, but kind of thinking about, their ability to empty out and to relax their anal sphincter ahead of time can be helpful as well.
Oh, and it looks like Naeem is also asking around timing of biologic discontinuation. And, we were just talking about this as well because data is evolving. But Katie, what do you think about that?
Yeah, so I think that, the guidelines recommend timing based on half-life. Of course, we want to minimize exposure to the baby while in the third trimester. We also try to kind of figure out timing in regards to minimizing, immunosuppression to mom after she's potentially had surgery or had a vaginal delivery. I personally I'm very practical about this, that sometimes we just don't get to decide, right? So sometimes, they go into labor after a Remicade infusion and that just happens. So I personally think that we do what we can. And if we're able to, anticipate, we try to time the last dose, within a couple of weeks of their anticipated delivery, knowing that it's not perfect. We do want to try to minimize interruptions in biologics to minimize risks for antibody formation, especially in the anti-TNF group. So that's, the kind of the group I think a little bit harder about. The risk of antibody formation in Entyvio and Stelara is very, very, very low, especially when patients have an interruption for non-active disease reasons, pregnancy being a good example, delivery being a good example. But if it is an anti-TNF, we try to time it based on their interval. So for example, if they're on every 8 weeks for Remicade, I'll probably try to dose it 6 weeks prior to the anticipated delivery, giving myself a little bit of room afterward to make sure they haven't developed, some sort of, infection or anything like that, and then giving them the dose afterward. My favorite thing to do is to, text page the resident on call and say, how are they doing 2 days after delivery? Everything okay? No evidence of infection. Okay. All right. Give the med, especially, Humira, which is often dosed, every week or two. You have a lot less, wiggle room there. So as long as they've done well with delivery and we're not seeing any evidence of infection after that, then I typically just go ahead and give it. I think there's definitely, it's not a perfect science. So it's just making sure that you're trying to kind of anticipate as best you can, but knowing that we can't. Great. Thanks for coming.
Thank you. I guess, anyone have any other questions? Okay. All right. Well, thank you, Katie, for joining us.
Thanks, Melissa. This has been fun.
All right.